All right, it's a minute after, so we will go ahead and get going. Good morning, everyone, and welcome to Dementia 101. For those who I haven't had the pleasure of meeting yet, my name is Amy, and I am the Director of Education here at Alzheimer's San Diego. We'll tell you more about ourselves as an organization toward the end of the program. For now, delighted to introduce you to my colleagues who are here co-presenting and supporting the webinar with me today. First is Alison, who is an MSW, Master of Social Work candidate and intern here at Alzheimer's San Diego, about to graduate any day now. And we are delighted to have her with us here today, co-presenting Dementia 101.
Good morning, everybody. I'm delighted to be here.
Going to be great. Also with us is Brooke. Brooke is an MSW and a member of our clinical services team. Also, colloquially, we just say one of our social workers on the team here at Alzheimer's San Diego. And Brooke will be with us here today answering questions in the Q&A, but also holding some of the questions. And we're going to take a couple of breaks and answer questions together, and she'll be supporting that side of the program. So happy to have you with us here today, Brooke.
Good to be here. Good morning, everybody.
And finally, we also have with us, let me get my slide moving here. We have Tin with us here today. Tin is the member of our volunteer tech team. So a volunteer of ours here at Alzheimer's San Diego. We could not do all of the things that we do as an organization without our great crew of volunteers here to help out if you're having any technical difficulty during the course of the program here today. We know that Zoom, while most of us have been using it for quite a while now, it still gets tricky and it can be hard to navigate sometimes. And if you're having any difficulty, please don't struggle. You can put a message in the chat and our volunteer will be keeping an eye on chat, can reach out to you. Or you can just call our office. You see the phone number there on screen. It will stay on screen throughout most of the program. Just call the office and they can connect you by phone. She can talk you through any difficulties that you're having with audio, video, closed captioning, any of those kinds of things. So thank you for being with us here today. We're so happy to have your help. So without further ado, let me just keep us moving. Here's our agenda, what we intend to cover here today. This is a lot of information. Dementia 101 is intended to be a broad overview of Alzheimer's disease and other types of dementia as well. We're going to talk about the symptoms and how they differ from normal age-related changes. We'll talk about risk factors and resources available for screening and what to expect during diagnosis during that process. We will talk about the various phases and stages of the disease, what the symptoms look like in the early, middle, and late stages of the disease, and what is recommended in the way of management of symptoms of dementia. And finally, we will be talking about things to be thinking about, planning for, talking about for the future. So safety issues, staying healthy, as both as a person living with dementia and as a care partner. This program is for everyone. And of course, resources for reaching out for more support. So with that, Alison, I'm going to hand the remote control over to you. I'll let you take it away.
Thank you. So let's get started talking about Alzheimer's disease and related dementias. There we go. We'll begin with vocabulary of dementia, which is somewhat difficult to understand. So we're going to start by clarifying some of these terms. As you can see on the slide here, the word dementia, when it comes to mind, do some of these words that you can see come up for you? You don't need to type them out. This is just a quick mental exercise. But it can get kind of confusing because some of these terms are used interchangeably with one another. So some of the terminology, we're going to try and clear up a bit of that today. Mild cognitive impairment, or also known as MCI, and sometimes referred to as minor neurocognitive disorder. That is diagnosed when a person experiences cognitive changes that go beyond normal age-related changes. So for example, the changes in memory or cognition are noticeable to the individual and or those around them, but it doesn't interfere with their daily activities. So it's important to know that it's different from Alzheimer's disease, and it's not pre-Alzheimer's. In fact, it's not even a type of dementia. Many people do end up getting dementia after a diagnosis of mild cognitive impairment, but it doesn't mean that you're going to get it. What happens is about half of the people who get a diagnosis with mild cognitive impairment end up getting dementia within the next 5 years. But what we think is that that's really just the doctors were catching early signs of dementia, and it was diagnosed as mild cognitive impairment. So we'll move on now to dementia. And it's not one specific disease, it's rather a syndrome. This word is often used kind of loosely, and it really shouldn't be, because it can be kind of confusing. So some of the symptoms of dementia are due to a medical condition, and some can be reversible and non-reversible. There are many types of dementia. And what happens is there's changes in the brain, and when you have changes in the areas listed here on this slide, including language, memory, visual perception, problem solving, and attention, if you have changes in 2 or more of those areas, that's when a dementia diagnosis can be given. But again, we need to look into that there's many different types of dementia. So the most common type, and what our association is named after, right? The Alzheimer's San Diego. It's the most common type of dementia. And it is an irreversible progressive brain disorder that we'll talk about in some more detail in a moment. So we'll start with young onset. This term is often used to describe types of dementias that happen to folks that are younger. We think of Alzheimer's disease as happening when we're older, but there are some types of dementia, including Alzheimer's disease, that can happen to folks who are younger. And so we use the term young onset to describe the forms of dementia that happen specifically for folks who are 64 years or younger. And it can show up in 50s, 40s, and even very rarely in your 30s. But the young onset forms of dementia account for only about 5 to 10% of all dementias. So we'll take a look at some other symptoms that are treatable, and they can cause cognitive changes. So it's important to remember that not all symptoms are caused by progressive conditions like Alzheimer's disease. Here on the slide, you can see a few common treatable conditions that sometimes produce symptoms that mimic the symptoms of dementia. So there's many reasons that people can have effects on their memory, cognitive function, attention as they age. It's good to get a medical exam and rule out these other types of treatable ailments that can cause symptoms that look like dementia. For example, a urinary tract infection that can cause drastic memory lapses and should be looked into immediately. So anytime someone starts showing a memory loss that's rapid, it's not likely due to Alzheimer's disease, because that's more of a slower decline. So it can be scary to see that, but it's just important to go get checked out and be aware of these types of changes. So as you can see, this dementia is not a specific type of disease. So it's, like we said before, it's more of a syndrome. There we go. So between about 60 to 80% of dementia is caused by Alzheimer's disease, the most common form. But while non-Alzheimer's types of dementia make up a smaller portion, a few of them are listed here and are also commonly known, such as vascular cognitive impairment, Lewy body dementia. And each type of dementia is caused by a different pathology in the brain. It produces its own unique set of symptoms. So many individuals are going to experience having mixed dementias, which is a term that we use when someone experiences more than one dementia at a time. It's unfortunate, but it's common. And so folks with Alzheimer's disease can also have vascular dementia, or folks with Lewy bodies dementia can also have a frontal temporal disorder, for example. And most dementias are believed to be caused by Alzheimer's disease. So let's get a little bit more into that disease in particular. So as we know, Dr. Alois Alzheimer's was first to describe this syndrome that would later come to bear his name. And his patient was admitted to a psychiatric hospital in Frankfurt, where he was working as a pathologist at the turn of the 20th century. She was only 51 years old, and her symptoms included memory loss, distortion, hallucinations, and radically changed behavior. So she continued to deteriorate for several years, and when she passed away, Dr. Alzheimer requested permission to conduct an autopsy. And it was there in her brain tissue that he found the presence of what we refer to today as the plaques and tangles. So these are the characteristics of Alzheimer's disease, and they're made up of two naturally occurring proteins called beta amyloid and tau. Today, we still don't understand what causes some people's brains to accumulate these proteins, and they remain difficult to detect in live brain tissue. The technology does exist, but it's very expensive and it's usually reserved for research. So most of the time, diagnosis occurs and it's only confirmed after an autopsy. So let's look at how the brain is affected. You can see here two very different looking images of a brain, and this graphic depiction of the damage that is caused by these plaques and tangles, you can see on the right side. It's extensive, and it starts in the part of the brain called the hippocampal region. So this is it's characteristic of Alzheimer's disease. It's the hippocampal region has the hippocampus. It's involved in creation and storage of short-term memory. So the hippocampus is the part of the brain that Alzheimer's disease typically starts with, and that's why the short-term memory and language changes are part of the earlier symptoms. And when we look at someone from the outside, it's hard to tell that there are so many changes going on inside. And while caring for someone with Alzheimer's disease or their related dementias, it's important to remember that we can't see what's going on the inside, but there are changes happening. So just briefly here, we're not going to go into all the different types of different parts of the brain, but it's just important to know that each type of dementia has a different cause, and it affects different regions of the brain. So a specific type of protein that is accumulating and where it's accumulating and how extensive the damage is going to determine the symptoms that a person experiences and how severe they are going to be. It's different for every person. And because there's so many factors that can influence that, it's difficult to predict what changes an individual will experience. So go ahead, and we're going to start with the symptoms.
Great. Thank you so much, Allison. Yeah, so Allison's done a nice job of giving you an overview of the different types of pathologies that might be affecting the brain tissue, the different regions of the brain. So I'll talk now a little bit about the symptoms themselves, because of course you can't see any of those things, those changes that are going on biologically, physically, but what we do see are outward changes in a person's memory and thinking and behavior and function. So first, very important to address the question that many people have when it comes to some of the most common symptoms of dementia that we're familiar with. Is this normal or is this not normal, right? I am often asked in social situations, more and more often, Amy, I will walk into the kitchen and have no idea why I walked into that kitchen, right? Is that something that I should be worrying about? I'm losing things all the time. I'm forgetting people's names. I used to be so good at remembering people's names. Is this something that I should be worried about? So important to know, our brains change as we age, our memories change, our ability to solve problems, to learn new things, to develop new skills, it slows down. That's a normal age-related change that we can all expect by, approximately middle age. Technically, it's really happening pretty young. We start to experience those changes in our early 30s. We just don't really notice them and feel them in our day-to-day lives until kind of midlife. So the difference between normal age-related change and something that might be something to worry about, not necessarily, oh, this is a clear sign that this is dementia, but a sign that something's going on and we probably ought to talk to the doctor about it, right? When a change represents a marked change from what was baseline or what was normal for that person. So if I, for example, have a really weak working memory, I can't especially for numbers, I can't hang on to a set of numbers for very long, more than a few seconds, really. You tell me a phone number and I have to dial it right now or it's just gone. That's just the way my memory works. That's always been the case and it will certainly continue to be the case. Whereas if somebody was always very good with numbers and we start to see that they're having difficulty with very simple calculations that used to be second nature to them, very simple for them, that might be something to worry about, right? So it's a change from what was baseline, what was normal for that person. Remember that because we're going to come back to it when we talk about the importance of screening. We have to know what our baseline is, right? The changes also need to be significant enough that they're interfering with daily life. So that example of someone like myself who can't hang on to a phone number, right? I have strategies, I have pens and Post-it notes everywhere for writing down what I need when I know I'm not going to be able to hang on to it. So not being able to do something like that, hang on memory wise to a phone number is not interfering with my daily function. Whereas if I were a bookkeeper, an accountant, somebody who worked with numbers for a living and I couldn't hang on to the memory of a number for more than a few seconds, or I couldn't do simple calculations, then that is going to interfere with my ability to do my work. Right. So when the changes are a significant change from baseline and they're interfering with your daily activities, then there's some cause for concern. It's also important to know that a person would be diagnosed with some form of dementia when there are changes in two or more what are called cognitive domains. So simply experiencing changes to your memory, but not having any changes with executive function, for example, problem solving, language, behavior, changes to the visual field, any of these other symptoms that I'm going to walk you through. If there's only changes in one area, while that may be something to be concerned about, it's not necessarily a symptom, an indicator that the person may be affected by dementia. So these are the criteria that we're looking for in sort of teasing out, is this change that someone is experiencing something normal, age-related, or is it possibly a sign of dementia? So let's talk about each of those 4 domains: normal versus not normal. Memory changes, as I mentioned, difficulty remembering names, in particular proper nouns, get harder for us to remember as we age. Misplaced, losing your keys, misplacing objects more often, eyeglasses, cell phones, all those things we're always carrying around, right? Those are normal age-related changes. The types of memory changes that are not normal, that are possibly symptoms that we want to be mindful of and aware of, getting lost in a familiar place, right? If you have lived or worked or shopped in the same neighborhood for many years and you struggle to find your way home from your familiar grocery store, right? That's not a normal age-related change. That is something to be concerned about. Losing your car keys, losing your cell phone, right? It's a normal frustration of daily life. That's not something we worry about, but when you have forgotten the function of those objects, right? I'm actually holding on to my car keys and I'm not aware that this is the object I need to use to get into the car, to make the car start, or I'm not recognizing the object or recognizing its function, and it's a familiar thing to me. That would be something to worry about. Normal age-related changes in thinking and problem solving. It is normal for, as we age, we can still, as long as our brain is healthy, we can continue to learn new things. We can continue to learn new technology, develop new skills, play new instruments, learn new languages, but we do it more slowly. That is just a reality of our aging brains. We're slower to learn new things. We solve problems more slowly, usually. We also experience normal age-related changes to our ability to pay attention and concentrate. Right. So when I'm driving a car, for example, I now, 20 years ago, 30 years ago, when I was a new driver, I could have music on, I could have people in the car, I could be paying attention to lots of different things. I probably shouldn't have been doing those things, but I felt like I could switch my attention back and forth so fast. It felt like I was multitasking pretty effectively. Right now that I'm middle-aged, I know I can't really do that. When I'm in a new place and I need to pay attention to what I'm doing behind the wheel, I need to turn down the radio. I need people in the car to be quiet, right? I need to focus my attention and my concentration. So this is something normal, an age-related change that we will all experience. Might also be chalked up to just good old-fashioned wisdom, better judgment as well. But there are some changes in thinking that are not normal age-related changes. So struggling with language, if that's a new struggle, right? Grasping for common words, common vocabulary, having new difficulties with reading, writing, handwriting changes that aren't attributable to arthritis, for example, or again, calculations, working with numbers in ways that used to be familiar and easy to a person, as well as changes to the way a person makes decisions, changes in their judgment, their insight, their ability to reason their way through a problem. Here's where we get into, it's important to know what was baseline and what was normal for a person, because of course people can make bad decisions and use poor judgment or limited insight throughout their lives. And if they do that in their later years as well, that's not necessarily a sign of dementia. Whereas if somebody was always a very thoughtful, plotting kind of a decision maker, and they suddenly become very impulsive, making big purchases or making big life decisions very impulsively, right? That's again, not always a sign of dementia, but a sign that something is going on that is worth looking into. There are physical symptoms of dementia as well. And this is important to recognize, I think, because this category of symptoms is the least understood of all of them. We are all going to experience vision changes, hearing changes, sensory, smell and touch and taste, sensory changes as we age to a certain extent. Some of that is normal. Also, losing muscular strength, losing some of our flexibility, our fascial tissue. Those are normal age-related changes that can be mitigated to some extent, of course, but that we wouldn't necessarily worry about. However, There are sensory and physical changes that come with dementia that are something to note, to bring to a physician's attention if you're seeing them. In particular, changes to the visual field are very common, even in very early stage dementia. Now, we're all, as we age, going to experience a shrinking of our peripheral field of vision to a certain extent. This is part of why driving gets to be more difficult as we get older, right? Our ability to see things out in the periphery of our vision just becomes a little bit more limited. But people with dementia can experience a very narrow field of peripheral vision that will change not only how they're sort of functioning and moving around throughout their lives and in their daily tasks, but it can also change things like your depth perception, your ability to interpret contrast. And so this will cause changes to a person's gait often. They'll begin to kind of stoop over because they have to pay more attention. They have to look, very close, as closely as they can to the ground in order to interpret what they're seeing. We will start to see more difficulty with balance. And unfortunately, people with dementia have a much higher risk of falling for all of these reasons. So changes to that visual, that field of vision, other sensory processing problems, right? A person with dementia doesn't necessarily lose hearing unless they also are having, problems with the structures in their ears. But what a person with dementia may experience is difficulty interpreting what is being heard. Right? The structures of your ears take in the sound, but your brain is where you hear, right? Your brain is where you interpret, oh, that is the sound of a smoke alarm. I need to get out of this room. Right. So being able to tell where in space something is coming from, being able to interpret it and to then apply sort of the logic, the judgment, the reason of what to do with that information, all of that can get impaired in a person with dementia. And then finally, behavioral changes are really important to talk about because they are not a normal part of aging, unlike the rest of these. For better or for worse, most of us, our personalities remain fairly stable throughout our lives. The type of person you are, generally friendly, outgoing, optimistic, glass half full kind of a person versus a person who's more pessimistic, who's a little more uptight, who's less friendly, right? Whoever you are is whoever you are. And for the most part, that's going to remain fairly stable through us for us as we age. It doesn't change just because we've gotten older. But in people with dementia, what we'll see are changes to their overall mood, their personalities. They begin to say and do things that are out of character for them. These are not always negative changes, by the way. If somebody was hard to get along with and unfriendly and they become very passive and easygoing, that's a change. Right, not necessarily something most people are going to report to their doctor, but it is something we want to pay attention to and notice when things are changing. More often, what we see is withdrawal, right? Not dramatic changes to a person's personality, but just beginning to withdraw socially, withdraw from people and places and activities that they enjoyed before, having a hard time getting started with new tasks, or just sort of changes in what is how a person's normal daily routines go. Now, you'll notice many of these sound a lot like depression and anxiety, and that is an important point. That there are many other things that can cause not only behavior changes, but memory, thinking, and physical changes as well. And so this is why screening and diagnosis is so important, because we really want to try to rule out, is this person dealing with stress, grief, depression, anxiety, right? Is there something else that might be causing these symptoms, or are they related to the possible symptoms of dementia? So I'm going to talk now about risk factors and screening and diagnosis, and then we're going to take a little break to address some of your questions. So again, if you have questions that are coming up, feel free to pop them in the Q&A, and we will be happy to discuss those together. So it really cannot be overstated, the impact that Alzheimer's disease and related dementias, sometimes abbreviated as ADRD, you may see some of that terminology around, the impact that these conditions are having on Americans, but also on people worldwide. So here in the US, we currently have close to 6 million people who are living with Alzheimer's or some form of dementia. Age is the primary risk factor, and so 1 in 9 people currently over age 65 is living with dementia in the US, and that risk only increases as we get older. So here in our county, we are significantly impacted purely because we have an older demographic here in San Diego County, nearly 84,000 people at last count. New numbers are expected to be released soon. We expect for that number to be higher. And it is the 3rd leading cause of death here in our county in people over age 65. It's the 6th leading cause of death nationwide. So the numbers are higher because we have an older population here in our county. And these conditions take a significant financial toll on people living with the disease as well as their care partners. A physical toll can be exhausting. It's really a 24/7 situation for people with dementia and their care partners. And of course, a significant emotional toll as well. So who's at risk of developing dementia? All of us. Age is the primary risk factor, as I mentioned before, and the risk just continues to go up as we get older. Sex is also a factor in Alzheimer's disease and many other forms of dementia as well. Women are at a significantly greater risk of developing Alzheimer's disease, which is as Alison described, the most common type of dementia. Men do have higher rates of vascular cognitive impairment and frontotemporal dementia, but women overall are impacted far more significantly by dementia. About 2/3 of all people living with Alzheimer's disease now are female. Health factors. This is a significant risk factor. None of these things, with one exception, none of these things cause dementia. They are risk factors. So if a person has hypertension, heart disease, or diabetes, they are considered to be at a higher risk of developing dementia because your brain is the biggest user of your blood supply. And so if there's any other health conditions that are affecting the blood flow to the brain, then that increases your risk of developing these conditions. Genetics and family history play a role, but it's not a well understood or considered to be a deeply significant role in most cases. There are genetic forms of Alzheimer's disease and frontotemporal dementias and a few others as well that are caused by a known genetic mutation that is inherited. Those are fairly rare forms of dementia. Most Alzheimer's disease, most other types of dementia are not inherited in the strictest sense of that word. But having a 1st-degree relative, a parent or a sibling with dementia certainly is known to increase one's personal risk. Education levels are a negative association. The more education one has, the lower the risk of developing dementia. Head trauma, here's the one exception to that causality that I was talking about before. We do now understand there is a clear association between head trauma that results in concussion and the development of certain types of dementia, one in particular called chronic traumatic encephalopathy, CTE. So a lot of professional athletes, veterans who sustained head trauma in combat, for example, these individuals are developing dementia at very high rates, and it is understood that there is that causal relationship there. Finally, the last of the known risk factors is Down syndrome. Individuals with Down syndrome have 3 copies of the 21st chromosome. And on that chromosome resides one of the markers that for the production of one of those proteins that Alison was talking about that is associated with Alzheimer's disease. So the long and the short of it is that most individuals with Down syndrome by middle age, by their 40s or 50s, have the pathology of Alzheimer's disease in their brains. those plaques and tangles that she was describing and showed you. And many of them, most of them, but not all, will develop clinical symptoms of dementia as a result of that. There are significant ethnic disparities here in the United States. The Latinx population, the Black populations in the United States absolutely experience greater rates of Alzheimer's disease and vascular cognitive impairment in particular. That is associated, that's nothing biological. There's no biological basis there. That is a result of the increased levels of these other health factors, right? More hypertension, more heart disease, more diabetes, more untreated hearing loss. I'm sorry, I failed to mention that one before. Those other health conditions, because of differences in access to healthcare, we see higher levels, higher rates of those health factors that then in turn increase those populations' risk of developing dementia. An important thing to notice about this list is that there are no known environmental risk factors or causes of Alzheimer's disease. It's not to say we won't find one, but nothing has been demonstrated clearly through large-scale validated research yet to be shown to cause Alzheimer's disease, although they are looking at exposure to certain fungus, certain molds, air pollution. There is research underway, but nothing has yet been definitively determined. So what can you do to lower your personal risk? We have a whole program devoted to this topic called Maintaining Your Brain Health, but in short, take good care of your heart. It's the best advice we can give you. Diet, a healthy diet, nutritious food, primarily plant-based, but also plenty of good, healthy fats. Your brain needs lots of fat. Needs good fats, I should say. Exercise and physical activity, staying active, keeping that blood flowing to the brain, staying intellectually engaged, staying socially connected, managing your emotional health for the reasons I was describing before. Many things, the mood disorders and emotional states can affect the functioning of your brain. So doing what you can to get plenty of sleep and to manage one's emotional health is really important for your brain health as well. So it's critically important that everyone over age 65 or younger, if you have other risk factors, be screened on a regular basis. We don't yet have sort of standardized medical protocols for screening, but important to know what your baseline is so that changes can be detected early. So that if there is one of those reversible causes that Alison described, depression, an infection, a thyroid condition, right? So a vitamin deficiency, if there is something treatable and reversible going on, we can detect those things, treat them, and correct the condition early. You can seek, if you are a Medicare beneficiary, you do have access to memory screening on an annual basis through your primary care provider, through your annual wellness visit. So do ask for that. And memory screening is also available at other community organizations, including ours. At the moment, they're on hiatus because we aren't providing in-person programming, and memory screening is done in person, but we do hope to be able to get back to that in the near future. So really important that we detect these conditions early and that we diagnose them accurately. It is tricky to be sure. Receiving a diagnosis is not an easy process, but if we find the condition early and we have an accurate assessment of what's going on, then the physician is able to sort of target the treatment, prescribe the right type of medication, for example, and engage the person and their support system in care planning early on. We do have some medications that are FDA approved for treating the symptoms of dementia. We'll be talking about those in a little bit here. They are more effective if they are started early, before the brain changes before the changes have really significantly changed the brain's chemistry. And of course, detecting these conditions early gives people time to engage in the important conversations that need to take place. We're going to be talking about the progression of the disease, and you will see it is a long, slow, progressive decline. There's plenty of time for having important discussions, putting important structures and care plans in place, participating in clinical research if you're interested in doing so. You have much more opportunity to do these things if we catch the condition early. Getting a diagnosis, not easy to do. We do recognize that there is still no kind of standard protocol for how we do this and when we do this and what tests are issued. So it's different for every person, but you're generally going to start with your primary care provider, if at all possible, because that's who knows you best, at least, theoretically speaking. Primary care providers can absolutely be trained to diagnose dementia, but it does require special training. So you want to ask your primary care doctor if this is an area where they feel comfortable, or should they be referring you out to a specialist. You may wish to get a second opinion regardless, right? A neurologist is a specialist of the brain. You want a neurologist who specializes in dementia, Alzheimer's, and other types of dementia. A geriatric psychiatrist may be involved because depression and dementia so often overlap. People frequently have both conditions, and these conditions mimic each other and also overlap and make each other worse, right? So geriatric psychiatrists are often involved in that process of getting a diagnosis because they can sort of tease out what's what, right? If we treat the depression, how much of the memory problem or cognitive changes are resolved. So geriatric psychiatry is a really important specialty in diagnosis and treatment of symptoms. Neuropsychiatrists and neuropsychologists are usually just involved in testing. They aren't treating people on an ongoing basis, but you may be referred to one through primary care or through a diagnostic clinic for some in-depth testing. And geriatricians are a terrific resource if you can find one, but we're in very short supply of geriatricians. These are primary care and internal medicine specialists in working with older patients. So what would you expect during the diagnosis? The workup will always start with basic medical history, taking a complete physical, doing lab work, because they're trying to rule out all that other stuff, right? What else might be going on in terms of electrolytes and thyroid and other conditions that they can identify and easily treat. There will be neurological exams. These are usually in office, paper and pencil, or face-to-face tactile types of tests that they're doing, many different inventories that can be used, different tools that are available in primary care settings, as well as in neurology or neuropsychology settings. They may, if they're having a hard time sort of teasing out, this is dementia, we're pretty sure about that, but we're having a hard time figuring out what type. You may be referred for more detailed neuropsychological testing, where they can really dig into those different cognitive domains and figure out, okay, yes, this looks like a behavioral variant of a frontotemporal dementia, for example. They may also refer you for brain imaging. Brain imaging is still, the technology is still pretty limited, but what we can see is atrophy, changes in function in certain regions of the brain that will indicate that this looks like, well, there's a lot of damage or a significant loss of function in this particular region of the brain. And so that appears to be characteristic of a Lewy body dementia versus an Alzheimer's disease, for example. And a really important part of the diagnosis, of course, is interviewing other people, because of the challenge of gathering accurate reports and information from a person who's experiencing memory loss. They may not have good insight into what's changing about them. So with that, Alison, excuse me, and Brooke, let's take a couple questions.
Okay, We got a couple here. First one is, are there any over-the-counter medications that help with memory?
Over-the-counter medications that help with memory. Excuse me. Sorry. There's nothing that has been, if anything is over the counter, there's nothing that has been FDA approved that has been tested and shown to have a demonstrated impact on improving a person's, we're talking about memory specifically, right? No, unfortunately. There are some FDA approved medications for their by prescription only that are available through a physician, that they don't improve memory loss, but what they do is sort of slow down the progression of symptoms. And Alison will be describing those shortly. But no, there are no supplements, vitamins, over-the-counter medications available at this time.
This next question is, if the person is experiencing changes in the physical and behavior domains, but their memory and thinking is intact, could that still be Alzheimer's?
It could definitely be dementia. This is a really good question. Alzheimer's disease in particular, for the reasons that Alison described well, very nearly always involves a person's memory, specifically their short-term memory, because of the changes in the hippocampus, the damage, that's where the disease tends to start. So nearly every person with Alzheimer's disease will have significant memory-related symptoms, even pretty early on. But it absolutely could be an indicator of a different type of dementia. Now, is there anything either one of you would add to that?
Yeah, I would say that, I know we keep saying dementia or Alzheimer's is different for everybody, but there are some telltale signs of behavior changes in, for example, frontal temporal dementia, behavior changes and physical changes in Lewy body dementia. Like those are kind of telltale signs where memory in short term is not affected. But you notice that they start behaving differently. The personality changes. They just aren't seeming themselves. It's important to get checked out, because it's really hard to get some of those diagnoses.
Yes. And keep in mind too, people who are very verbal, I myself am one of those people, if you haven't noticed. People who are very verbal and also people who are very social can sometimes really mask memory problems. So there may be some memory issues going on that just aren't readily apparent, but that could be identified through the course of more in-depth testing.
Okay, and there's a couple people who are interested in the hearing loss aspect of dementia, how that's related, kind of how the hearing loss piece is treated.
Yes, it's a really interesting field of study, and there is emerging evidence out there, research and evidence out there that there is an association between untreated hearing loss and the development of dementia. Yes, first I'll say in our webinar library, there is a recording of a program that we did with a local audiologist on this topic, the connection between hearing and cognition. If you want to learn more, you can learn directly from him. It was a great program. So that's available in our webinar library. But yes, what the research is starting to show, this is fairly sort of, it's emerging as a known risk factor for dementia, that a person who has lived with untreated hearing loss over the course of a few years, that regions of the brain involved in hearing begin to basically atrophy, and it will actually increase a person's risk of developing not Alzheimer's specifically, but dementia more broadly. So hearing loss is very, very common. Nearly all of us are going to experience hearing loss to a certain extent as we age. So getting your hearing checked on a regular basis and correcting for any hearing loss is a really important way you can help take care of your brain health.
And just to follow up on that, what is it typically hearing aids are treatment for that? Or is there anything else that's ever done?
Yes, I wish there was better treatment options for hearing loss. And Allison and Brooke, feel free to chime in if you know of something that I don't. But certainly hearing aids, which are not well covered by insurance, by the way, they're expensive. It's not an accessible treatment for a lot of people. But yes, the use of hearing aids is the most broadly used treatment. But also I'll just say, think about protecting your hearing too, if it's not too late, right? Being mindful of sound, of loud music exposure through earbuds and headphones that we're all getting these days, and using earplugs as needed. Yeah.
Here's one that's interesting. Why is Alzheimer's disease so much more prevalent now than it was in the 50s?
Interesting. Alison, you want to take that one? That's a good question.
Well, I mean, I would say that we're getting better at diagnosing. So it may seem to be more prevalent, but we're just more, technology and science has improved over time. So we're seeing signs sooner. We're having more options for research to diagnose and then confirm in an autopsy and really see what's going on.
Yeah, absolutely. We also live longer. So there are more people in the age group where we now know over age 65, you got that 1 in 9 chance. Over age 85, it's almost 1 in 3. It's about 40% of people over age 85. And 50, 60 years ago, we didn't have such a big population of people in that age group. So yeah, that's it. There's more people with it because we've aged into it. And also we're better at knowing it when we see it. Yeah. Anything else?
Let's see here. Someone is just confirming that, when you're talking about medication, that Prevagen would fall under, is that effective?
Right. Yes, that's an example of something that has not been proven to be effective. While yes, the commercials claim that it's clinically proven, if you look for the research, it simply isn't there. Clinically proven is not scientific terminology. It doesn't actually mean anything. And there is not solid sort of gold standard, large scale validated research to back up many of the claims that it makes about memory. Specifically, I am talking about improving changes to a person who already has brain changes related to dementia, whether or not it can, improve a healthy person's memory. There may be some research related to that that I'm not aware of. Yeah. Okay. Well, Allison, so keep your questions coming. We'll break again in a few minutes here, but Allison, I'm going to hand the remote back to you, or it looks like you still have it, and you can take it away.
Okay, so some of you or you yourself may know someone that's received a diagnosis. And what can we expect now? Let's talk a little bit about the procession of Alzheimer's and other dementias. So the progression of the disease, like we've mentioned before, no two people experience dementia in the same way. But there are some general patterns that we can look for. So the progression is usually slow decline, but it can be variable for individuals. So it's important to know what the individual's baseline is. Like Amy mentioned before, she's not good with numbers. Me personally, I'm not great with names. I could be shaking your hand and immediately forget your name as soon as you told it to me. So while it's important, to know it's different for everybody, just knowing that person individually and their baseline. So we're going to go into the different stages, but as far as generally speaking, the middle stage is the longest. And since diagnoses the diagnosis of dementia or Alzheimer's is happening earlier, like we just talked about, because of us living longer, advances in science. The early stage can actually last quite a while. So let's look into that a little bit more in depth in a couple of slides. It's really important to note that diagnosis does not mean incapacity. So we actually want to just really reiterate that a diagnosis of dementia doesn't mean you're incapacitated, doesn't mean you can't make decisions for yourself. So many people only have mild symptoms in that early stage for a really long period of time, which doesn't mean you immediately lose all of your individual independence and driver's license, for example. Your level of function that determines your legal or decision-making capacity, it doesn't change just because you have a diagnosis. While you're not going to lose your driver's license immediately after receiving a diagnosis, the DMV will be notified. It's just something to keep an eye on and to make sure that you're continuing to be safe. So let's go into the different stages. Like we mentioned, the earlier mild stage is going to have more mild symptoms, and it can be a slow decline over several years. There's occasional confusion, disorientation, and problems with instrumental activities of daily living. So brushing your teeth, the order of things may be a little bit confusing, and you might have to stop to think, okay, no, I have to put the toothpaste on first, and it may just be second nature for most of the time, but there may be occasions when that becomes a little bit more confusing, and you may have to guide your person. Oh, okay, don't forget we should put the toothpaste on first before we start brushing, or we need to rinse, and the kind of the order of things starts to get a little bit more disorienting. So moving on to the middle or moderate stage here. So it can be the longer of the stages. I know we said it can vary from 2 to 20 years, which doesn't tell you a whole lot, but typically someone in the middle stage, you notice more of a decline from the earlier stages. They need a little bit more help with things. So there's an increase in memory loss, an increase in confusion, an increase in that disorientation we talked about. Their language and communication challenges, maybe the sentences that used to just flow, if they were very verbal, they stutter a little bit, or they have to stop and find their words. It may take them a little bit of time to fully understand what you're saying to them. So it's important to be patient and slow down and understand that the brain is trying to communicate, but it's more challenging at that time. So the difficulty of those daily living activities, personal care, personal hygiene, all those things are just going to be more challenging. And there may be more of a safety concern because, like Amy had mentioned, getting lost in a familiar neighborhood or location is more of a telltale sign. So if that individual goes for a walk around the neighborhood, they may need some more supervision just to make sure that they get home safely. And usually the shorter length of the disease is the late or the severe stage. So here we have very limited communication and limited verbal communication specifically. They may be able to understand more, but not be able to communicate back verbally. Typically you need a lot more supervision. It may be very unsafe to leave that person for any amount of time. Like we mentioned, the fall risk can be more severe because coordination is challenging. So ultimately, there is a difficulty in all of the functions, and that includes chewing and swallowing. So eating becomes more difficult, softer foods, more liquids become easier to digest and to consume. And then there's just a reduction in physical activity and dependent mobility, so that 24-hour supervision is really crucial to maintain safety. So throughout the disease, people living with dementia can still make and communicate decisions. They can still express feelings and respond to emotional connections. And like Amy had mentioned earlier, it's important to, when you're connecting and communicating, to really look for that emotional concern instead of what they're saying. The words can come out differently than what they're actually meaning. So it's important to think about dementia as a series of losses, and at every stage and every level of ability, we want to be able to feel loved and to show love. So like it says here on the slide, like engaging in modified work and recreational activities is important. Connecting through sensory and nonverbal communication, a touch, holding hand, a hug, those kinds of things really can go a long way, a lot more than say words can. And unfortunately right now we're limited in our ability to be able to do those kinds of physical communications. It is still important to remember that those are really can have a lasting effect. All right, so now we're going to talk a little bit about symptom management and get into some of those medications that we had briefly gone into. So we're not healthcare professionals, so we're not going to go super deep into medications, but on the slide you can see some of the current FDA approved medications. There's 5, and they are approved for memory, symptoms of memory and cognitive decline in Alzheimer's disease. So they don't impact the disease itself, but they can delay the worsening of the symptoms for many individuals. So keep in mind, these medications are prescribed, and they can address other symptoms of the disease as well, like anxiety and depression. You could have other medications prescribed for that as well, agitation, sleep disturbance, but these can affect how the approved Alzheimer's disease or dementia medications work. So it's really important to talk to your doctor about that. Okay, so I think new normal is a term we've been hearing a lot lately throughout the last year. So this is a different kind of new normal, adapting to a new normal with memory and cognitive impairment, or a different form of dementia. That can be addressed with medication a little bit, but that's just a small piece to this disease management puzzle. There are many changes that we can make to help address some of the cognitive, physical, and behavioral symptoms that a person might experience. So it's important, you can see here on the slide, to again address the physical and the emotional needs. Maybe they can't communicate that they need to use the restroom, but you look for symptoms of maybe they're pulling on their shirt or their pants, and they're uncomfortable. And adapting to this new environment can be challenging, and so behavioral changes and redirecting attention and validating that, like Amy had mentioned, validating someone's emotions and experiences, while that might not be reality, it's their reality. So it's really important to just adjust how the care partner responds, because we cannot change how the person with dementia is responding. So in addition to our services, we are here to help you along this journey. There's also many other credible sources of information, and don't feel like you have to rush to write these down. All these slides are going to be shared through an email after the program, where you can easily see the links and go to these different sites and get some more information about Alzheimer's disease and related dementias. So I believe now we're going to wrap up for some more questions. Is that right, Amy?
Yes, sorry, couldn't get myself to unmute there. Yes, we will break now for a few more questions. Brooke, what has come in?
Well, good ones here. Thoughts or ideas on how to have a conversation about concerns with someone who seems to be in the early stages of dementia?
Yes, I love this question. If you are, based on what you've learned here today, you're thinking to yourself, yes, there's somebody that I know that I need to address this. We need to talk about it. What should I do? It's a really tough subject. Again, Allison and Brooke, feel free to chime in, add anything you'd like here. But my favorite approach, I think first, I'll just say there's no one strategy that works for every person. And you are always welcome to call our office and talk with a member of our clinical services team about this particular conversation, right? Here's the situation. Here's what I've observed. And here are some things about their particular history and personality that might be relevant to help you sort of frame a conversation. But very generally speaking, my favorite approach is to emphasize how many different conditions there are that could be causing these changes. Remember that list that Alison showed earlier. This could be something as simple and easy to treat as chronic dehydration, malnutrition, meaning a deficiency in a particular type of B vitamin, for example. There could be a simple explanation for these changes that I'm seeing. And so let's go find out what's going on instead of opening up the conversation with the word Alzheimer's, right? I'm concerned that you have dementia, this condition for which there is no treatment or cure, right? That type of conversation is frightening and tends to close people down. And as Alison described, it often makes people think first about all the things they're going to lose. I'm not going to be able to drive. I'm not going to be able to make choices in my life. None of those things are necessarily true. And I think opening the conversation, being open about it, I think there's a lot of stigma around memory and cognition, and just saying there's nothing to be ashamed of here. Many people experience memory changes like the ones that I've noticed in you. I'd love to help you figure out what's going on. I also really recommend making it something that you're going to do together, if at all possible. This is the beauty of going to one of the community memory screenings, like the ones that we used to offer at Alzheimer's San Diego. We hope to be offering again soon, where you can say, I know of this place that does free memory testing. Let's go get our memory tested, right? So it becomes something, I'm not afraid to do it either. It becomes something we are going to do together. Let's go talk to the doctor, right? Anything else you would both suggest?
Yeah, I think you covered it.
Yeah.
Great.
Okay. So this person says that they've heard it's controversial that if a person is in the middle stages of dementia, that it may be controversial to consider prescribing them dementia medication, since it's not curing, and it may be kind of dragging on or extending the condition. What is your take on that?
Yeah, this is a really good question, and an important ethical consideration, I think, for a lot of families and healthcare providers. First, I just clarify, though, that the medications that are available, the Aricept, the Namenda, for example, those are the two most commonly prescribed. These are not life-extending medications. What they do is slow down the progression of symptoms. They are known to be most effective when started earlier in the disease process, much less effective if the person is already in the mid or late stage, maybe even not effective at all, but they're not going to extend the person's life or slow down the disease. They're not actually slowing down the progression of the disease. What they do is just sort of delay the progression of the disease, kind of move that line that you saw on that graph, move it out a little further. So what the question is really about is, do we continue to pay for the drugs, right? Put the person living with dementia and their care partner through the stress of having to administer drugs once or twice a day, which can be very challenging. As anyone who's cared for someone with dementia knows, there can be swallowing problems, there can be behavioral issues that cause a person to refuse medication. And then of course there are side effects, right? There's often GI side effects, nausea, diarrhea. So exposing the person to the financial cost, the emotional cost, and the side effects with little to no clinical benefit. In most cases, a physician or a hospice provider or a pharmacist would advise, not continuing those medications. But it is a very personal decision. I'd always refer you to a pharmacist for a consult if you have questions about a physician's recommendations around any of those drugs. Yeah, great question.
Okay. Do you suggest responding positively or agreeing when a person thinks that someone is stealing from them? This person says that they want their mom to feel comfortable in her living situation, but she thinks her caregivers are stealing from her.
Oh gosh. Yeah, that's a good question, a pretty common scenario. Alison, can I hand that one to you? And I'm happy to add in if needed.
Yeah, absolutely. And we have some other great classes that kind of go into different ways to communicate and to respond to behavior changes. And anxiety or paranoia around stealing is super common with a lot of different types of dementia, not just Alzheimer's. And it can be really difficult to deal with because the person might consistently believe that all the time. And this delusion that someone is stealing for them, even though you might be able to prove really easily that they're not, it may not, it may be challenging for them to understand that. So it's important to just validate that emotion, and really redirecting is the best kind of method to handling the situation immediately, trying to figure out, is there some other need that needs to be met? Is there any way that we can make this person feel more comfortable and more comfortable with the people that they feel like are stealing from them? Is there maybe something else going on? Maybe they're agitated with how that person cares for them, or maybe it really is just that things get moved around when they're cleaned, and it frustrates them because they forget where they put something. They could be moving it themselves. There's so many different reasons why an individual might have these feelings, but it's the best thing that you can do is to just let them know that you're there, that you care, that you're going to do everything you can to take care of them, that they're safe, that they're loved, and try to redirect them to a different activity that is calming and soothing and makes them happy.
Great. Nothing I can add there. That's right. Letting a person feel heard and understood, even if you're really sure no one's stealing and everything's fine. Don't dismiss that, right? Don't dismiss that feeling. Address it. Let them express it. Yeah, great advice. Thank you.
Okay, another question here. How do you handle a situation where a person has been diagnosed by a neurologist, but the person denies that they have dementia and thinks it's just normal aging?
Yes, really hard. So there is a condition, we talk about this a lot in a lot of our caregiving programs. There is a condition that's very common in people living with dementia, and it's called anosognosia. Brooke, could I have you put in the chat, just spell that word out because it's kind of tricky. Anosognosia is a condition wherein a person lacks insight into their own disability. And this happens in many conditions, lots of mental illness, but it happens very commonly in people with dementia. About 50% of people with early stage dementia don't have an awareness of what's changing with them. So what it looks like from the outside is a person being in denial, a person refusing to admit that they've been diagnosed or that anything is changing, when in reality what often is happening is that they do not remember, right? It's the nature of this disease. Remember that damage in the hippocampus? That's where the memory of that doctor's appointment, where a doctor told you that you have Alzheimer's disease, that's where that would have been encoded. And that memory may very well not have stuck. So when people are telling you if anyone told me right now that I have a diagnosis of diabetes, I'd say, well, I've never been diagnosed with diabetes. What are you talking about? Right. So that's really the situation that they find themselves in, being unable to recall a memory. But when they challenge that, it sounds to us like they're just refusing to admit it. Right. So you just have to kind of recognize, where is this person on that spectrum of insight and understanding about their diagnosis. They may not be able to remember, to understand, to retain information about a diagnosis. And so you have to kind of work with it. So that's what our communication skills class is all about. If you're interacting with someone who doesn't know why are these people in my house trying to help me? I don't need help, right? Learning to work around and communicate around their lack of insight is really important.
All right. So this person is caring for their father who's in the middle stages of dementia. He's not able to drive anymore or find his way home. A couple times he's snuck out of the house and with the car and taken hours to get home. He's asking, do they need to hide the keys? How can they prevent that from happening?
Ooh, so tough. We're going to talk here in the last section of the program about safety, and driving is one of the key safety things we need to be talking about. Again, I'll refer you to a program that's in our webinar library and that we offer semi-regularly, called Driving and Memory Loss, where we really sort of dig into this important topic. But I mean, yes, if a person is not safe to be driving, as with, cars, firearms, medications, whatever the issue may be, when we're clear that the person does not have the ability to manage these things safely, we do have a duty and a responsibility to limit their access to those things. So yes, disabling the car, removing the car, whatever needs to be done, might need to be done. Yeah.
Okay. Any tips on helping a family member who's caring for someone with dementia who lives far away?
Yes. Again, I'll refer you to our webinar library. Sorry to keep doing that, but we do have programs on all these topics because these are great questions that many people have. We have a program on the topic of long distance caregiving that is designed to sort of address those questions. I would say, just a very basic general answer: ask them what they need, right? Let them vent and let them tell you, what their day-to-day is like. Listen to them and offer practical help to whatever extent that you can. But I think generally, as with all of us, the most important thing that caregivers need is to feel heard, to be seen, to be recognized for the stresses that they're under. So you're asking the question is the great first start. Yeah.
Okay, one more question here. It's similar to some things we've talked about, but this person's father was diagnosed with amnestic MCI, and the neuropsychologist suggested seeing a geriatrician, but he's not open to following up or getting further help after that. Any other suggestions on how to get him to follow up?
On how to get the patient to follow up? I wasn't totally clear. Okay, so it's the patient who is resistant to.
Correct.
Yeah.
Yes.
Well, I would say it's an amnestic MCI is that diagnosis that Alison was talking about at the beginning, mild cognitive impairment, meaning that the person is experiencing memory changes. That's what amnestic means. There's memory changes, but not other changes. So it doesn't meet that criteria of a dementia diagnosis. And I would say in this case that, while yes, we know that the person is at a greater risk of getting a diagnosis of dementia later down the road, if there's a lot of resistance to that and it's just going to cause a lot of friction, I would say continuing to receive care from their primary care physician, to be followed, but to be checked every year, get rechecked so that the primary care physician will be able to detect changes if it's beginning to look closer to something like a dementia diagnosis, then you might want to push the specialist a little harder. But I would say with a diagnosis of amnestic MCI, not to treat it lightly, but to say a good primary care physician should be able to help them manage that pretty well.
All right, that's it for now.
Okay, it's really kind of a matter of picking your battles, right? As they say. Okay. Take the remote control back and we will talk about that important issue of safety and also staying healthy and finding resources for more support. So I'll be very brief about these issues. They are big, difficult, challenging topics about which, as you've heard, we have many other education programs as well as supportive information and supportive resources that our clinical services team can connect you with. But we want to bring them to your attention because these are important things to be thinking about for the future if you or someone that you know are diagnosed with some form of progressive dementia, right? Doing what we can to keep the home safe or think about alternative housing arrangements because of the risk of falls, because of the risk of household injuries, burns, accidentally flooding, scalding, having difficulty managing medication and taking medications incorrectly, right? Those types of household incidents can be prevented. The risk of those things can be lowered to a certain extent, but it takes some thinking ahead and it takes some work. Preventing abuse, very important to know. People with dementia are much more likely than the general population to be victims of especially financial scams, but other forms of elder and dependent abuse, as well as self-neglect, which is a form of elder and dependent abuse. So we want you to be aware. We want you to be empowered to make a referral to Adult Protective Services if you're concerned about somebody's well-being. You don't have to have proof. If you have any suspicion that somebody is a victim of abuse, anyone can make a report to the local Adult Protective Services organization. Driving and firearms, as I mentioned already during the Q&A, very important safety concerns, very difficult topics for people to talk about. We know that. We have a lot of resources around this. We can provide transportation alternatives. We can help you navigate talking to the doctor about an evaluation. We can help you connect to the DMV directly to request that a person be reevaluated if you're concerned. When it comes to firearms and cars, I mean, these are people's property. It's not easy to simply take them away from someone. And in most cases, it's actually illegal to do so, and you would be punished for that. So this is tricky terrain to navigate, but we can help you with it. When it comes to firearms in particular, I just want to note that we do have a gun lock program at Alzheimer's San Diego, simple cable gun locks that are operated with a key that a person can hang on to. The cable goes through the barrel of the firearm and renders it inoperable. So you don't have to have that conversation about getting rid of the firearms. You can just lock them so that they can't cause any harm. So really big topics, and I don't mean to oversimplify. I just want to give you some examples of some of the resources that are available through our organization and elsewhere in the community. Caregiver stress, tremendously impactful. Another one of those things that really can't be overstated. Caring for someone with dementia, even if you're not the live-in hands-on caregiver, is incredibly stressful. Caregivers need support. We offer a variety of support groups, social work services, respite care, to alleviate some of that stress. And we can also connect families to other programs, day programs, the Southern Caregiver Resource Center, which offers a variety of free support and services to caregivers of people with disabilities, including dementia. Caregiver stress absolutely is a significant risk factor, not only for the caregiver, but for the person living with dementia. And then, of course, wandering. We did hear in one of the questions about the impact, the risk of wandering, a very high risk behavior in people with dementia. The term just refers to getting lost, right? On foot, in a vehicle, on public transit. It can happen in any variety of ways. The data tells us that about 60% of people with dementia wander. They get lost at some point in the course of the disease process. But anecdotally, I think most of us would tell you it probably happens to nearly everybody at some point. There's probably just not totally accurate reporting on this front. But we have some great programs here in San Diego County to help respond to wandering when it happens. In addition to, strategies we can help caregivers with to prevent it from happening, to lower the risk, to keep the house safer, to secure the perimeter, to alert caregivers when a door opens. Lots of tools that can be used, including GPS, right, for personal tracking. There's lots of resources out there, but in particular, I want to make sure you're aware of a program called Take Me Home. And it's operated by the San Diego Sheriff's Department. You see the URL there on the slide, which again, we will email out to everyone. Take Me Home is a free registry run by the Sheriff's Department here in San Diego County, secure and available to anybody who's at risk of getting lost. So not just people with dementia, but also people with autism, other conditions that may cause a person to elope, as it is called, right? To leave and then become disoriented and not be able to find their way home, where you can upload a photograph and some key information about this person so that if they become lost, you don't wait and file missing persons, right? You just call 911 and say, my person is not where I expected them to be. They're lost. I need help finding them. And then the Sheriff's Department can send that information out to the local law enforcement jurisdiction, wherever they were last seen, where you think they might be, and they can start that search in a fast and effective way. A terrific program, gets a lot of national attention. We're very proud of it, but it's only as effective as the number of people who get registered in it. So we really recommend at any stage of the game, if it's just an early MCI diagnosis or late stage dementia, don't assume that a person in late stage dementia can't get lost. There are some remarkable stories out there, and it's a really dangerous, risky situation for them. So Take Me Home, as well as things like Medical Alert or other types of ID that you can use to identify a person as having memory loss, connect them to a database. A Good Samaritan or a first responder can call that number, find out who to call and how to get that person back home as quickly as possible. So all of those resources and much more is available on the safety page of our website. So finally, a really important closing set of thoughts here. It's just this is going to be a physically, emotionally, financially demanding journey. There's just no easy way around that. It's important that you prepare for it. While we don't yet have an effective form of treatment or cure for these diseases, we do know a lot about how to live well through the journey as a person affected by the disease or as a care partner. So learn what you can, develop those new communication techniques, build your support network. We can help you with that. If you don't have one, we can help you identify a support group, leveraging people in your neighborhood and your personal communities and networks who might be able to help you in ways you're not even really able to think about, right? Get yourself a break. That's really important. Respite. It's a fancy word for rest, right? If it's daily 5 minutes or it's a full-blown week vacation, whatever it is that you need, everybody needs a break from caregiving. And if you're a person living with dementia, I assure you, you need a break from your caregiver too, right? So having opportunities to separate, to take mental breaks, but also know that the person is going to be safe and well taken care of is really important. Tend to your own health, your own mental health as well, whether you're the person living with the diagnosis or a care partner. I think people tend to pour everything into the disease and the diagnosis and into caregiving in particular. But we often say here, you can't pour from an empty cup, right? You have nothing to give others if you've given it all away. So make sure you're attending to, if you've got high blood pressure, if you haven't seen a dentist in a while, right? Whatever the issues might be, don't let your own self-care and maintenance fall by the wayside. And above all else, try to maintain a sense of humor. Lots of lots of really great research out there that shows the benefits of laughing, but also just being able to kind of see the light side, the absurdity of some of these situations that we find ourselves in as people living with dementia or as care partners to them. Being able to see the humor in those situations has tremendous impacts on a person's health overall. So don't be afraid to start these conversations. This is why I love that question that we got earlier. Please bring it up if you're concerned about someone. If you're concerned about yourself, ask other people in your life, right? I've been learning more about dementia and I'm worrying about myself. What do you think, right? It's really empowering and important that people talk about these things, and it's never too early to start sort of breaching some of these important topics, talking about updating or creating advanced healthcare directives, thinking about the home and whether or not it's safe and going to be a good environment for the journey here. Those tough conversations about driving, making decisions about long-term care and how we're going to pay for it, building or strengthening your support system, and of course, staying as healthy as you can throughout this journey. So that all of that is what we're here for as an organization. Alzheimer San Diego is a local independent nonprofit. We're not part of any, we're not affiliated with any national organizations. We are located here in San Diego County and we just serve San Diego County. Although of course, we know there's lots of long distance caregivers and folks who reach out to us from outside the county, and our services are available to you as well. You can talk to one of our dementia experts, that's Brooke and the rest of the clinical services team. Reach them by phone, by email. You can find a support group. Brooke is sending out a link in the chat, a form that you can fill out to request assistance from one of our social workers, a member of our clinical services team. If you want to know more about any of these resources or get connected to any of our other local nonprofits and organizations that can help, please fill that form out and a member of our team will get back in touch with you. Lots of education programming, as you've already found your way to us. Please keep learning, please keep attending, asking great questions and sharing resources with us. That's terrific. We have social activities and outings. We have exercise programs online on our website. We have outings in the community. We do critter drive-ins right now. Of course, we're doing everything safe, either remote, online, or safe socially distanced programs out in the community. We have a program called Baseballs, which is a reminiscence baseball themed program. Lots of social engagement opportunities to not sort of isolate and not get out there because of these challenges related to dementia. And then two very important programs to be aware of are Vitals, Volunteers in Touch, and our virtual ALS Companions program. So these are volunteer-based programs overseen by a social worker on our team who will get to know you and assess, what type of help you need. Vitals volunteers make phone calls to people with dementia who live alone to check in, provide support, and to provide assistance if needed. And virtual ALS Companions hopefully we'll get back to being able to do in-person respite visits soon, but at the moment we're still doing virtual companionship visits. So it's just somebody that kind of hangs out, an extra friend, somebody that, tells stories, listens to your stories, plays games, goes on walks, doing just fun social engagement for a few hours to give caregivers a little bit of a break. So any of those programs you want to know more about, please reach out and let us know. If you or someone that you know have a new diagnosis, we have a program called Take Charge for people. It's a 5-week education and support series to kind of learn everything you need to know, all the planning you need to be thinking about, the documents to be getting in place, the conversations to start having, a really wonderful resource for people with dementia and a care partner to come to together. It's currently a virtual series. We'll see what the summer will bring, but our next session will start this summer. So please reach out if you're interested. There is some screening requirements for that. So here's how you can reach us. Our website has a whole library of information, as well as our webinar library, but also just a lot of great tip sheets and resources in English and in Spanish. You can reach out, call, email, even send a live chat from our website. That's a real member of our staff that answers those chats. So if you have questions, you need resources, or you're just having a rough day of it and you need to talk to somebody, please reach out and let us know. And there is, again, that request form, the link to which Brooke has been putting out in the chat. So a couple of upcoming programs. Our next two programs are focused specifically on caregivers. Next Tuesday, we're doing our panel presentation, Confessions of a Caregiver, Women's Perspectives on Caregiving, next Tuesday, May 4th. And then communication skills, the week following, this is the program that Alison was talking about, where we talk a lot about validation techniques and redirection strategies for caregivers. Many more programs on the calendar. You can find all of that online. So with that, I will wrap things up. I thank my co-presenter, Alison, for being with me here today, doing a great job. Thank you, Brooke, for handling all of those questions and doing a great job of keeping us organized here today. And thank you, Tin, for helping people with tech support and generally being a huge helping hand to us in the education program. We really appreciate that. All of you, we thank you for your great questions and your sharing and your insight. We would love your feedback on the program. When this webinar ends, you're going to be redirected to a quick survey. We'd love your feedback on it. It's anonymous, so please share openly, honestly, and tell us how else we can help. If there's other things that you need from us, please let us know. We will be emailing out a copy of these slides and a link to our webinar library. And if there's anything else you need, we're here to help. So just reach out anytime.